pleasure to talk to you today. I'm going to present to you about the survey which Sydney Catalyst decided to undertake really as a baseline to try and get an idea of how MDTs were functioning across the 7 hospitals that are members of Sydney Catalyst. So they are RPA and Lifehouse, Concord Hospital, St Vincent's, Orange and Dubbo hospitals in Western New South Wales, and Port Macquarie and Coffs Harbour in the north. And I wanted to make sure that I acknowledge my co-authors here, particularly Michelle Lai, the project officer, who did the enormous amount of work behind getting all our ethics and governance approvals and setting up the survey and really taking a lead role in this project. So a big thank you to her. So, as I said, Sydney Catalyst study where we really wanted to scope what the MDT functioning was across those 7 institutions to understand how many MDTs were set up and running, and to really be very clear in our objectives that we made sure that we understood how care is being organised. And we wanted to make the distinction as a group working together to say that we recognise that there's really 3 levels of care. One is general multidisciplinary care, which doesn't rely on a team or a meeting, but it's that interaction, that overall approach to care, with the assumption that all of the discussion and corridor conversations and all of the things that happen outside of the meeting are still working together towards having a coordinated approach towards cancer care for our patients. The multidisciplinary teams are typically, not exclusively, the medical or the clinical oncology team with other, as Lindley said, non-core members who come into that for the different groups. And then that multidisciplinary team meetings are the actual meeting. And I'm going to sort of just interchangeably talk about those 3 different distinctions throughout the presentation. So coming back to the second definition then, MDT's meetings are focusing on this alliance between medical and health professionals and really focusing on their willingness to deliver care that's based on evidence-based clinical decisions and to ensure that care is delivered in a coordinated fashion, and it encourages patients to take an active role in their care. So our aims were to look at the MDTs across the different sites, not doing direct comparisons of hospital versus hospital, but really to understand more the functional and organisational aspects, but to explore similarities and differences according to 3 different distinctions: metro versus regional teams, the common and rare tumour teams, and then those who are engaged in professional activities and those who say that's not happening for them at the moment. And our specific aim was really to look at how evidence is informing MDT team meeting team practice. So using the Cancer Institute's surveys that they administered in 2006, 2008 and 2011, we took the core items out of that as well as adding our own items into that survey. And they were grouped into 5 categories that you see there: meeting purpose, organisation, resources and documentation, estimates about caseloads, the use of evidence and quality assurance, patient involvement and supportive care needs, and strengths and weaknesses, and having some opportunity there for the teams to give us their own ideas and thoughts about where they were doing well and where they really were not doing so well and would like some help. So we emailed an invitation out to all the MDT chairs for all 37 teams that we identified, and then if there was no response within 2 weeks, we contacted a second team member and invited them to participate, and we used CanRefer as our main source of making sure that we knew who the chair was and who an additional person was to invite. And we administered it using SurveyMonkey. So as I mentioned, just in terms of those 3 main categories of what we were interested in, the way that we categorise what was common tumours versus rare tumours was according to the AIHW classification. So for New South Wales, for Australia, but particularly looking at the New South Wales data, saying that where there were more than 5,000 cases a year, they were considered the common tumour groups, or where there was less than 5,000, that they were the more rare. We used ARIA, geographical classification, to classify the hospital sites, and we used one survey item to distinguish between those teams that were engaged in professional development or not. So that's just gives you a general overview of those 37 teams from the 7 different hospitals, and we were really pleased that 100%, so all of them, completed the survey and were really keen and were really willing to participate in the research, so we were pretty delighted with that. You'll see there 30% of them were in regional area, metropolitan, 7 in regional, and just to note that the rare tumour meetings only took place in metropolitan hospitals. And you can see from the table there that there were what you would expect in terms of the spread of the different tumour groups, with urological, breast and upper GI, colorectal being the main ones, slightly less in haematological, lung and general oncology. General oncology, I think, being mostly in the regional areas where they have smaller patient numbers coming through. And then the rare cancer groups for head and neck, neuro, liver, gynae, oncology, thyroid, sarcoma, pituitary and pelvic exenteration. So our survey was completed just by one person from each group, so a little bit different to what Linley's done with the survey in Westmead. We've just gone for one person from each, and you can see it on for the majority, for 2/3, it was the chair who completed the survey, or another specialist clinician or specialist nurse, and only in 3% of cases did we have the data manager completing the survey for us. So I should have done some nice graphs that match with Linley's, because when she started presenting I thought, oh, this looks very familiar. And I think we've probably got resoundingly similar results in terms of most teams are reporting, not surprisingly, that the main purpose of their meetings is for treatment decision making, or in slightly less of the 88% of the case for diagnostic decision making, but as opposed to Linley 60%, we had 70% who said they were engaging in those meetings with an educational purpose in mind. We actually found across the teams there was fairly consistently good documentation during the meetings. There was either an MDT coordinator or a registrar or somebody appointed who was an admin officer within the team who was taking down minutes or information about what was being recommended for each case. But quite frequently that information went absolutely nowhere. So I'd very much concur with what Linley was saying. The information's being recorded and it's going towards the patient's electronic medical record in most instances, but that tended to be as far as it was going. So similar to what Linley was saying, at Westmead we had less than 20% of people using that information then to feed back to GPs what management decisions were being recommended, and most MDTs just didn't have the capacity to do that on a regular basis. We had less than half had terms of reference in place, and about 1/3 had intake criteria for how they were deciding who would attend the meeting. And as you can see from the table on this slide, when we asked the teams about use of evidence within their meetings, they very clearly said that consensus was still the main way that decisions were made about treatment. Guidelines in about 57% of the case were being used, and other sources of evidence-based medicine were there for about 30% of the teams. And I think probably one of the standout features of this survey was that that sort of response was pretty consistent across the teams, that consensus is the main focus for how treatment decisions are being made. Fewer teams felt that they had the resources to engage in quality assurance or quality improvement activities. And if they did, they were using clinical practice guidelines as their basis in about 2/3 of the case. Just over half were doing regular reviews and following up on what patient outcomes were, but again, there was relatively few opportunities then to check whether those recommendations were being followed over a period of time. So very little opportunity there for audit and feedback. About half the teams reported that they were engaged in professional development activities. Similar to what we had Fran presenting on, there were those classic meetings like ASCO where there were people coming back from large scientific meetings and on an infrequent basis. Really that there was not that many opportunities during meetings to talk about the research results that were coming from journal articles or from scientific presentations that the team members were seeing in other ways. Thankfully, registrars did get an opportunity to present to the team in about a third of all cases. So just ignore the fact that I've repeated the same table on this. I just wanted to carry over. So out of all of the comparisons that we did, we found, and there were 92 different analyses that we had done, there were only 3 significant results that came out, which we were quite surprised about. But the main differences, as you can see on the screen there, was around quality assurance and that the rare cancer MDTs were significantly more likely to engage in the review of patient outcomes than the common cancer MDTs. And in terms of research evidence, that the metropolitan MDTs were significantly more likely to present or discuss recent research results than the regional MDTs. And they were both statistically significant in terms of those differences, I think probably speak to the fact that the metropolitan MDTs have that exposure to going to conferences, to regularly being able to engage with their peers, and perhaps the regional MDTs are not having those opportunities in the same way for that for that opportunity to talk about the research. In terms of professional development, you can see on the third point there that the MDTs who engaged in professional development were significantly more likely to name collaboration as a strength of their team than those who didn't. So I think it really feeds in nicely to what Linley's been talking about with where teams are on an overall spectrum in their development, and that those teams that are resourced and do have the time to engage in professional development have those collaborative structures and that good communication happening on a regular basis. I think perhaps one of the more troubling things that came out of the survey very clearly was the lack of information that teams have available to them in a consistent way. And this very much feeds into what Tim and both Linley have mentioned in terms of the lack of databases and the lack of resources to conduct internal audits. So 78% of the team said that they didn't conduct any kind of internal audit, and they didn't have the capacity to do that to confirm that treatment decisions reflected best practice. And while I don't expect you to necessarily be interested in the detail of this slide, what I want to convey to you is that when we asked teams 3 core questions around caseload, one about, the first one there being, what was your total tumour caseload in the past 12 months, the number of patients who were discussed in the last 12 months, and being able to estimate what proportion of those patients were newly diagnosed, the majority of teams couldn't answer those questions. So only 14 out of 37 teams could give us that information. They had real trouble being able to have that information at their fingertips so that they could actually estimate who their population is, where they're coming from, why they're being presented, what the main areas are that they could potentially then improve on as a team. That information is just lacking. So I think, again, it reinforces a really clear message to say data is not part and parcel of MDT functioning to enable internal audits to be conducted. So just to sum up, we think the first Australian study to focus on the use of evidence in MDT decision making across multiple tumour types, And we think that the results will really be interesting to start generating debate and discussion about how we can make improvements in the MDT process to better support teams and to enable them really to do more than just the presentation of their patients on a weekly basis, but to think about where there are opportunities for using things like standardised templates or using a database, so that the teams are really empowered to think about what it is that they're doing on a weekly basis and how they can improve their practice over time. Most teams seem to include professional development in some capacity on a regular basis, and collegiality is highly valued, but there's certainly a lot of room for development and growth there for teams to be engaged in professional development activities. Just in terms of the findings, we were quite surprised to find so few differences across those 3 different groupings that we looked at. So again, wanted to say thank you to all our participating sites, and particularly Karen Gorzinska and Liz Connolly, who gave us an enormous amount of help in the regional sites and at St Vincent's, and the manuscripts almost over the line at the Asia Pacific Journal of Clinical Oncology. So that's it from me. Thanks, Tim.
Thanks, Nicole. So obviously an interesting parallel process in here. So
Yeah.
We've got similar issues. So does anybody have any, we've got a few minutes for questions. Does anybody have questions for Nicole? Norbert, and then I'll Renee.
Nicole, just again a very basic question. I mean, it's great to see that consensus is kind of the majority driver in the decision making, but how is this consensus informed? I mean, in 30% or 35% of cases, it's actually evidence-based. Isn't that a bit worrying? And then in the other cases, is it then basically the head honcho says X and then everybody follows, or how is that consensus formed?
Look, I think, Norbert, perhaps our survey is a bit crude in terms of being able to really identify at a granular measure how decisions are being made. But it is, I suppose, troubling that they're saying consensus with or without guidelines or evidence is still the format if they can't articulate why something wouldn't be guided by evidence. And I don't think that perhaps the survey gives us the answers, and it's an issue to go and unpack with the teams and to look at those issues in a much more detailed way. And I think someone else was going to
I was just going to comment. Sometimes I think the consensus in those meetings is because they're the complex cases, and sometimes it's a bit of an evidence-free zone. You know, thinking about a project that we ran in the last sort of couple of years, patients who have rectal polyps removed and adenocarcinomas found in that polyp. What do you do with that patient? Well, there's no evidence on that. So as a team, we had to come up with a guideline that we were happy to follow and at least do something standard for those patients in our team. So that would be a consensus, I guess, in the absence of good evidence.
I think, as Nicole said, there's a lot of unpacking to be done of what it actually means around that, certainly. Other comments on that? I'll go from there.
Any kind of fairly ignorant in this area, but I'm puzzled why there's resistance to a standard data reporting form that couldn't be flicked off to the GP and put into a database. Wouldn't that make reporting simpler and clearer so that somebody just succinctly summarises everything?
I think it is, and certainly.
The GP actually so.
Yeah, with the lung cancer MDT at Concord and RPA, we just trialled using a template, and over the last 18 months have been implementing that and saying, what does it take to have an electronic template that's been developed between clinicians and the information technology staff within the local health district, and to have that as part of the MDT reporting, where you can have pre-populated items but then also have the registrar or the meeting documenter entering information live in the meeting. and we've set up a process to do that, but it took 18 months of resources and negotiating and to evaluate it and to actually, we then did follow-up with 60 GPs and evaluated with them, and they said, this is fantastic, why isn't everybody doing this? And it should be a simple process. So I think there are small pockets of where those sorts of projects are happening, and it needs to be implemented on a much broader scale, because there's no reason why we shouldn't be using those sorts of resources with teams.
It shouldn't be that hard.
No.
I mean, that's the bizarre thing. I mean, I think some of it, those, I'll come to Lizzie in a moment, but I think some of it's culture as well. I mean, I think the teams hadn't really thought about it, to be honest, about the GPs weren't getting that information, and then, you know, we have to go through a whole process to actually, what do the GPs actually want to know?
It's not just the GPs, it will also inform the research database, so you just have one form propagated to the patient record of GPs in the database.
Yeah, that's I think an advantage of saying if you can get your information technology team to put this in as a standard part of a database, then you can use the same data for multiple purposes, and obviously part of it is for audit and feedback for the team, but reporting to GPs is certainly a great purpose for that information.
Yeah, I was just really going to reiterate. I wanted to say I'm very impressed with how you've managed to get a scientific basis into something. I'm actually struggling with that because there are so many variables and I'm not quite. But with respect to the GP, we've managed to do it once again at one of our teams that has a live data entry database, and it's automated that it goes. But there are issues. I mean, some doctors actually want to have them writing to the GPs, so they have to overcome that cultural aspect. And the other thing, you have to make sure that the admin time isn't too much. Do you?
I might just speak louder. I mean, there are some issue with surgeon because sometimes they have a recommendation, they just don't follow the recommendation, and they don't want to follow the recommendation. They will tell you that, oh, my patient is different. They actually don't want to be mandatory, so that's why that they actually don't want anyone else to know. They want the recommendation when you come to them, and they take it. So I'm not sure how we can progress further. Because in UK, it's mandatory. If it's a recommendation MDT, that's it, you have to follow.
Yes.
But in here, in Australia, at least that I'm aware of, there's too many, there are issues, it's discussed. The surgeon always can say, oh, my patient is different. 90 years old, oh yeah, he's very fit. I should do surgery, or, there are times that I don't know how to overcome that. I don't know how, as a group, that we can, that's why we always like that to have a meeting, not just a surgeon are there, that we have Mark is there, the oncologist are there, so that they can give us some perspective and say, but normally we actually don't disagree, because once you disagree, there'll be an argument between two surgeons, we don't want to see it. And if Mark say that, oh, this patient is, I should see it first, then we'll say, okay, Mark will send it to you. At least that is easier than that.
It's a whole different cultural world to try and influence, isn't it?
But I come back to data being really centred around some of that, and I mean, you would have maybe all seen IBM Watson buying, was it to Orion? Is it Orion? Cancer. So IBM Watson Oncology has just bought into the first private chemotherapy group in Queensland, actually. And we're looking at doing a pilot with them in New South Wales. And so that's when they started to really munch hundreds of thousands of patient experiences into a clinical decision support tool where you can actually start to, so I think you really look at variation in care, and you get really detailed information about your patient against lots of others. And then I think you get to start to move away from this, my patients are different. I'm also working with another group called Lorica Healthcare. I don't know if you've heard of Lorica, but they've got unbelievably rich data about surgical outcomes and treatment regimes for the private sector at this moment, but it's really impressive and startling about how much data they've got. So, and with risk adjustment for different cases and so on. So I think over the next 5 years we're going to see a massive change in that data that's available. But we're just kind of right down in the dark ages. And I think once that improves, then I think that kind of variation in care and other things will come through. But we still have to have that flexibility, don't we, really, about what with every patient is different. And I think that's going to be a huge debate once we have more of this information about when can you digress. And just to advertise the data conference we've got coming up on the 21st of July, we've actually got the Chief Medical Information Officer from Moffitt Cancer Centre in the US coming over, and they've got a fully integrated CERN system. And I've looked at, they're just launching chemotherapy protocols in lung cancer, where they have a clinically derived and agreed on cascading set of protocols for every patient based on lots and lots of parameters. And if you go off protocol, then you have to justify that and sign it off. It's just fully systemized, and it's kind of quite a different approach to it. So if you want to look at that, come on the 21st of July. So I think things like that are going to really transform how MDTs operate.